There are numerous items that need to be addressed or management that needs to be initiated for this patient, starting with PPE, gloves, glasses. There was no danger response, airway, breathing, or hemorrhage checks, so these need to be done. And then the patient obviously has to have his clothes removed, need to dry him off because he's wet. You can assume he's just come out of the pool, and application of defib pads for the analysis of a rhythm in case that he is in a shockable rhythm. Compression depth, way too deep and way too fast, so a third of the depth and allowing for full recoil of the chest, slowing it down, and then ventilations of 15 to 2 for 2-person CPR. And then suction is required as the patient has drowned. It would be a reasonable assumption that airway will need to be suctioned. Here you can see the compression rate and ratio has changed and the person is using one-handed CPR technique.
Hi Kim, what we've got here, we've got a 3-year-old post-drowning cardiac arrest. So what I need you to do is, can you just grab a towel for me, remove the patient's jacket and dry him off, and then we're going to put the defib pads on him. We're going to analyse.
The aim here whilst removing the patient's clothes is to try and not cease CPR at all and see if you can continue going. If not, you have to pause for a second.
Help the patient. Move your hands.
We'll just roll in quickly and we'll just pause CPR just for a sec.
Ready?
Set, yep. Okay, back on. We'll plug in. Alright, so we're analysing, hands off. Analysing. And no shock advice, so Sarah, jump back on, we'll keep doing CPR.
Early intubation for these patients who are significantly hypoxic is absolutely paramount. So early ETT setup, and as the picture displays, set up like so, and then makes the procedure seamless and easy. When attempting to intubate a patient whilst in cardiac arrest, it is absolutely essential that CPR does not stop. If you are unable to intubate, you just pause and wait until you're able to do it at another time, but intubation should never be at the expense of CPR. Once a patient has been successfully intubated, I attach the bag and give some ventilations and then go through my checks. These include tube misting, rise and fall of the chest, listening to the chest and the stomach, and usually the gold standard end tidal waveform. But in cardiac arrest, this is a little bit more difficult, but if you have an end tidal, you can ascertain that you're in the trachea. Securing of the tube is absolutely essential. You don't want the tube to come out and have dislodgement of it. Here we are tying off the tube with a piece of cloth and getting one of the ALS crews to hold the bag and ventilate the patient at the appropriate rate. Listening to the chest and the stomach for confirmation of endotracheal placement in the trachea. Insertion of a bite block. It's important that a nasogastric tube or an orogastric tube is inserted early in the paediatric patient, especially in cardiac arrest or when being ventilated. As the patient was being bag valve masked early on, air can easily get into the stomach and distend the stomach. What this does is impedes on the diaphragm, and as the children have flatter diaphragms and use their diaphragm for breathing, it can impede on their ventilation and make this more difficult and oxygenation harder. The naso or orogastric tube is measured from the stomach to the ear and up to the corner of the nose or mouth. When checking for insertion of the orogastric tube, inflation of the tube into the stomach whilst listening to the stomach and listening for bubbles, having my partner do that whilst I'm inflating the stomach, and then withdrawing on the plunger as well to remove any gastric contents. Whilst I would be at the airway head end of the patient and intubating the patient, putting the orogastric in, my microparamedic partner would be putting IV access in simultaneously. If IV access was unable to be gained within 90 seconds as per the children's guidelines, IO access is appropriate. Here is a setup of my IV cannulation equipment for paediatric cannulation. Here we are gaining access to the paediatric patient. Whilst I would be putting in a cannula, or my microparamedic partner putting in a cannula, CPR would be continuing, ventilation would be continuing, and another paramedic that wasn't tasked with any management would be drawing up drugs ready to be used throughout the cardiac arrest. Intra-arrest management and pharmacology would include adrenaline, 10 mics per kilo, and for this patient they would weigh 14 kilos, so that's 140 mics, and this would be given at 4-minute intervals and drawn out of a 1 in 10,000 adrenaline ampule. Normal saline, TKVO, continue CPR at a rate of 15 compressions to 2 ventilations once the patient's been intubated, rhythm check every 2 minutes, and changing of CPR operator every 2 minutes, and a pulse jerk with that. And during this, I would also be preparing for ROSC. So drawing up an adrenaline infusion, 3 milligrams made up to 50 mils of normal saline, and a morph-midaz infusion, 15 milligrams of morphine and midazolam in anticipation for ROSC and to maintain sedation for intubation. Once ROSC was achieved, I would maintain the endotracheal tube with a morph and midazolam infusion, running at 0.1 to 0.2 milligrams per kilo per hour, and depending on transport times, for me this would be a lengthy transport, so I would make that up to a 30 milligram of morph and midaz, as a 15 and 15 would be used up too quickly and would be drawing up multiple infusions. Perfusion support with an adrenaline infusion starting at 0.05 to mics per kilo per minute and up to a max of 1 mic a kilo a minute. And post-intubation paralysis, consult the clinician who would get onto the kids, and this would be 0.1 milligrams per kilo pancuronium. Also, what can assist is placing a collar lightly and loosely around the patient. This can assist in minimizing head movement, which can assist in maintaining the endotracheal tube in the trachea and keeping it secure. And whilst the patient was in ROSC, I would be turning up the patient's PEEP up to at least 5 centimeters of water. Recent discussions with paediatric anaesthetists are all in favour of PEEP in the child, and especially in the drowning patient who requires alveoli recruitment for better oxygenation and ventilation. And these patients are extremely prone to atelectasis, which further complicates VQ mismatch and oxygenation of the patient. So PEEP recruits these alveoli and keeps them open for oxygenation. Other things to take into consideration would be patient's destination. For me, I would be getting HEMS support, as they would be able to then transport to the Royal Children's, as this patient needs paediatric intensive care unit and will need ongoing support and management for several days. Early notification of HEMS would be the best way to go about this. Once on scene and cardiac arrest in a 3-year-old was ascertained, on the phone to get HEMS moving to us. Other support would be obviously required for the mother and the father and any family members there. So early activation of police to get on scene and support services that would be able to help the family in this extremely difficult time and assist them in getting to Melbourne.